Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture, today we'll be discussing on what we call a squint or strabismus or crossed eye. Very frequently you will see in a person with third, fourth or sixth cranial nerve palsy, and there will be many other causes for strabismus, maybe congenital or maybe acquired. So we'll be discussing that part. So squint, strabismus or crossed eye. If the axis of the two eyeball is not parallel, we'll use the word strabismus or squint or crossed eye. If there is deviation of one eye inward, we call isotropia. If eye is abducted, it is called exotropia. And if eye is elevated, hyper, and if eye is depressed, it is called hypertropia. These are some of the words which will be very frequently utilized in this lecture. As routine definition, misalignment of the eye, or we call abnormal axis of the eye. Normally when the person in a normal position, both eyeball is having a parallel axis. If the axis is deviated or there is an abnormal axis of one eye, that is squint or strabismus or crossed eye. And whenever the person develops this, binocular vision will be affected. The malaligned eye or misalignment of eye will give rise to a blurred vision, and the eye which has got a proper axis will give a sharp image, and that will produce diplopia. Now there are few terms which we'll be using. When you say phoria, means there is deviation of the eye which you cannot make out. You will be able to make it much better by cover uncover test. While tropia is a word which is utilized if there is a clear cut manifest deviation, means it can be seen, and depending upon the type of deviation, if there is an inward deviation, it is called iso, and depending upon latent or manifest, either we call isophoria or isotropia. We'll be talking more of manifest only, so we'll be using that word. When there is a deviation of the eyeball outwards, or we call abducted, it is called exotropia or exophoria. If it is upward deviation, it is called hyper, and if it is downward, we call as a hypo, and if it is rotation, torsion, it is called torsion. Now this particular can be congenital or acquired. If it is since birth, it is called congenital, and after birth, it is called acquired. Now if the two eyeball are in two different directions, then it is called dissociate squint or dissociate deviation. If it is because of involvement of the extraocular muscle and it persists in all the range of movement, then it is called non-comitant or paralytic squint, while the movement of the eyeball is present, but it is seen in only some of the movements, then it is used word non-paralytic or concomitant squint. These are the some of the words. And once in a while, you see a person with an excess of epicanthal fold. You call it as a pseudo strabismus. So you can have orthophoria, squint, strabismus. Here you can see there is a inward. So this is isotropia. Here you can see this is inward, or we call adduction or nasal. So it is called isotropia. This is exotropia. This eyeball is having elevation, so hypertropia. This is downward, so hypotropia. Here you can see this is inward or nasal, or we call medial or adduction. So isotropia. This is outwards or temporal or lateral or abduction. So exotropia, this is upward, hypertropia, this is downward, hypertropia. Now this is a normal position. So it is called primary position. Now these are called secondary positions. Means you are asking the person to move laterally to the left, to the right, to up and down. And then you ask the person to look up and out, two combinations. So that is called tertiary positions. This is upward and inward, or upward and left side and right side. This will be left side, this will be right side. So upward and to the right, upward and to the left, downward and to the right. Sorry, this will be left and this will be downward and right. This will be pure upward, pure downward, to the right, to the left. And this will be normal position. So together now we'll be mentioning some of the words. Either you call squint, strabismus or crossed eye. And you can divide them into true strabismus or pseudo strabismus. If it is not seen clearly, and you can demonstrate by doing cover uncover test, we call phoria. And if it is clear cut manifest deviation, we call it a tropia. For medial, or we call iso, now common word utilized is iso. You can use medial squint, nasal squint, adductor squint, inward squint or convergent squint. These are the different words utilized. But now the common word utilized is iso. Exo, outward, abductor, temporal or lateral. Upward is also called hyper, downward is called hypo, and torsion is called cyclotropia. Or you can have combination of the two. I've already discussed concomitant and non-concomitant, or we call as paralytic and non-paralytic. Non-concomitant is also called as an incomitant. Then if two are in a two different direction, then we call it a dissociate squint or dissociate deviation, depending upon the etiology, congenital and acquired. These are different terminology, or you can call them as classification. So broadly it is classified into comitant and incomitant. Comitant means deviation is similar in all direction of the gaze, and incomitant means deviation varies in different direction of the gaze. So that particular, or you can say concomitant is non-paralytic, concomitant is non-paralytic, incomitant or non-comitant is paralytic squint. So deviation will be seen in different direction of the gaze. Etiology can be idiopathic, can be due to refractive error, or can be restrictive, or can be paralytic. We call paralysis of extraocular muscle. Restrictive classical example in case of exophthalmos. and maybe because of refractive error, and very, very rarely sensory. These are the some of the etiology and terminology you can utilize. So squint can be pseudo, latent we call it phoria, and manifest we call tropia. That can be tropia can be further divided into comitant and incomitant. And incomitant can be paralytic, restrictive, or spastic. These are the terms which are being utilized. ESO or called as a latent convergent. Cyclophoria is latent torsional. Encyclo means it is inward. Excyclo means outward. These are the words which you commonly utilize. If it is constantly present, you can use the word constant. If it is intermittent, it is called intermittent. And if it is periodic, it is called periodic strabismus. Or also you can use the word temporary and constant. These are some of the words which are commonly being utilized. Unilateral or uniocular. Uniocular strabismus is one in which the squinting eye is always in the same except under condition of testing which forces the squinting eye to take up the fixation. While bilateral or alternating strabismus is one in which the deviation may occur in either eye or in which there is no obvious preference for one eye to remain fixing eye. So this is bilateral or alternating, or you call uniocular and unilateral. There is one another called as accommodative, means when you try to accommodate. So deviation induced by influence of accommodation, it is called accommodative convergent squint. And when the deviation presents in absence of accommodation, it is called non-accommodative squint. The deviation will increase on the exercise of accommodation. So you can have a divergent squint. Here you can see this eye is deviated, so it is exotropia. This is elevated, hypertropia. This is inward or isotropia, or we call convergent squint. These are the few words. So among etiology, it can be congenital or acquired. Among acquired, 3, 4th and 6th nerve palsy, which can be because of brainstem damage like infection, trauma, tumor or vascular, or may be seen also in case of myasthenia gravis, or because of visual disturbances like corneal opacity, or maybe pseudo squint because of the epicanthal fold, excess of epicanthal fold in an eyelid. Some of the visual disturbances, say maybe like keratoconus, corneal opacity, or idiopathic, or very rarely iatrogenic. So the commonest causes are idiopathic, refractive error, restrictive, classical example like exophthalmos, paralytic, very frequently because of the 3rd, 4th and 6th cranial nerve palsy, and very, very rarely sensory. Restriction is very frequently because of the trapping or shortening of the muscle. In a 3rd cranial nerve palsy, you will have a dilated pupil and eyeball will be having a squint downwards and outwards. This will be paralytic squint. While isotropia will be very frequently seen in a 6th cranial nerve palsy. These are two most common, and in a case of 4th cranial nerve palsy, now it is not mentioned here, but in a 4th cranial nerve palsy, the eyeball will be deviated because the normal action of the 4th cranial nerve is downwards and outwards, so eyeball will be deviated iso and hyper. So you will have that type of deviation. So concomitant squint and incomitant we already discussed. And in a children, very frequently, retinoblastoma can produce a blindness and loss of eye, and person can even die. And you can have blindness also because of congenital cataract. That can also produce squint. Because of squint, person will have very frequently, we call diplopia. So person will be confused and slowly brain will adapt so that mild misaligned eye will have a blurred vision. So brain will slowly stop adapting that and you will have a loss of vision in that eye. And that will be labeled as amblyopia. And person will not have stereopsis, means both eye will not have a common vision. And you can see that particular strabismus either may be latent or may be manifest deviation. So appearance of the eyeball axis will be different. So these are all the different actions: superior rectus, inferior rectus, medial, lateral, inferior oblique, superior oblique. So these are all the different action. So if one is paralyzed, the unopposed action, eyeball will be deviated to that side. So these are all the different action. Lateral rectus will be outward or abduction or temporal or lateral movement, while medial rectus will be adduction, nasal, medial or inward. Elevation or upward movement will be done by superior rectus and inferior oblique, while downward movement will be by superior oblique, inferior rectus. So superior oblique is supplied by fourth cranial nerve, lateral rectus by sixth cranial nerve, and rest of the muscle by third cranial nerve. So third cranial will supply medial rectus, superior rectus, inferior rectus, and inferior oblique. So those four muscles will be supplied by third cranial nerve. And because of misalignment, you will have a diplopia. So person will have no stereopsis, means three-dimensional vision will be affected. Visual acuity, particularly of the misaligned eye, will slowly lose the vision, we call amblyopia. And because of diplopia, person will have a confusion and the appearance will be peculiar because of the deviated eye. So that will be seen in a clinical features. So appearance will be very peculiar and you can find out whether it is concomitant or non-concomitant or whether it is phoria or tropia, that is latent or manifest, by doing cover uncover test. And there are the ways of writing down. So suppose if the right eye has isotropia, so it is written as RET, and if it is exo, it is written as RXT. If right eye is hypertropia, then it is written as RHT. So these are the words which are being written. And right hypo, there is no specific terminology. And if it is alternating, so alternating isotropia ET, alternating exotropia XT. So that will be the word which will be utilized. So for isophoria E, for exo X, right eye, left eye, hypertropia, hyperphoria, then intermittent. These are the terms. Forget about that. Better to mention the full words. Pseudo isotropia, or also called as pseudo deviation, and here you can see that it is pseudo exotropia because of excess of epicanthal fold. So epicanthal fold is more, so it will appear as if there is Isotropia. So that can be identified by cover uncover test and examination. So misalignment of the two eye, absence of binocular vision, and you will have a concomitant or incomitant squint. Incomitant is paralytic squint, concomitant is you will see in particular movement only. Angle of deviation is equal in all directions. So while checking for the strabismus, history, inspection, visual acuity, refractory error, and then you can go for cover uncover test. Then you can go for examination, complete eye examination, diplopia test, triangular prism test, etc. All those should be examined. I am not an expert in that field. Some ophthalmologists can explain you nicely. So age is important. What are the complaints? Birth history, family history, personal history. Because diabetes, hypertension and thyroid disorders can produce temporary squint can be seen, and particularly in a thyroid disorder it can be restrictive variety of squint. So try to identify that. Yes, look can be deceptive. So inspection, head position, facial asymmetry, look also for nystagmus, etc. So good examination will be always helpful. So try to identify whether it is concomitant or non-concomitant, whether it is phoria or tropia, what variety, whether it is exo, iso, hypo, hyper or divergent, all those should be looked for. And due to strabismus, the child will also acquire the head position to make vision as clear as possible. So even the person can have tilted head. So you try to identify different types of squint. This can be for your quiz. You try to identify which eye is affected. See here it is hyper. This is, you can see that here this is lateral deviation. So that will be exo. Here this is inward and this is upward deviation. So this is hypertropia. This is also hyper. And this is iso, inward. Now you can see that when you lift the epicanthal fold, you can see that is normal. Here it looks like a medial squint, but then it is normal. Excess of medial rectus movement can also look like squint. So it can be monocular, binocular, and when it is binocular, the word utilized is version or vergence. And invergence, convergence, divergence, and as far as version is concerned, conjugated movements are there. So it is called dextroversion, levoversion, etc. So combination of the movement, dextroversion with elevation, dextroversion with depression. This is levo. So you are looking to the left side. So levoversion with elevation, levoversion with depression. And this is pure elevation, pure depression. So these are all the different movements you can have. So adduction, abduction, you look for that. Elevation and depression. These are vergence movements you try to look for and try to identify the type of squint by different movements. Then you can go for cover uncover test or alternate cover test and try to identify Nutan. So you will have to find out, is the squint latent, then you label that as aphoria. If squint is manifest, tropia, then direction of deviation, etc. You try to identify. So by doing cover uncover test, you will be able to differentiate some of the latent squint you will be able to identify. So do that particular test. That is to detect and confirm tropias and phoria. Phoria, cover uncover test. Then there is prism cover test to find out the total deviation. Cover test is to detect heterophoria. Uncover test is to detect cover test is for tropia. Uncover test is for phoria. So you try to do that. This is prism cover test. Then there is one test called as a Krimsky test. By covering the eye with a glass and try to identify what type of squint it is. This is cover test. You can detect exotropia, esotropia, then hypertropia, exophoria, that you can detect. This is one another test. I am not aware of it in detail. Bilskowski test. I am not aware exactly how it is done, etc. So there are few words called tropia and phoria. You have got cover uncover test. You have got paralytic, non-paralytic, concomitant, incomitant, restrictive, etc. These are all the words which are being utilized in strabismus and squint. We have already covered majority of them. As far as the treatment part is concerned, the person can be treated with refractive correction like glasses, or maybe by using patch or by a prism glasses. And if person requires surgery, then recession or resection method, and occasionally you can use Botox injection to maintain the alignment of the two eyes. Just listen to this.
All working together to control where the eyes are looking. Some muscles pull the eyes up or down.
This is upward, downward movements.
Or right, and
this is
work to rotate the eyes when the head is not straight.
Right and left. This is rotation.
The eyes move together to focus on the same
This is
spot.
Conjugated movement. If both eye axis is normal, you will have a binocular vision. If the axis changes, we call that as a strabismus.
This is called
Strabismus. And because of strabismus, what will happen? This is a conjugated movement.
Each eye sends a signal to the brain.
When both eye axis is parallel,
are combined to make one three-dimensional
both
view.
images can superimpose and you get a three-dimensional view.
In different directions due to strabismus.
But if axis changes and if there is a strabismus, one eye which is misaligned will have a blurred vision and you will have a diplopia.
When a child has strabismus, The
So
brain
slowly over a
sometimes
period
wants
of
to
time,
ignore the image from the
you will
misaligned
have
eye.
that
If this is
side
allowed to
eye
continue,
will lose the
child
vision
may never
because the
develop
brain
good
will
depth
not
perception
accept it.
and may lose
So
sight
we'll lose the
permanently
sight
in the
permanently
misaligned
in a
eye.
misaligned eye.
Older patients that develop strabismus may experience double vision. Treatment options depend on the
And
type
because of
and
double
severity
vision, they
of
find
the
lot of
strabismus.
problems in daily
For some
activity.
patients, a non-surgical treatment is the best option. Sometimes the misaligned eye
So one
can
of
be
the
treated
treatment
with
is surgery.
prescription eyeglasses. In some patients,
Another
the
is
eye doctor may recommend
eyeglasses
patching one of
like
the
patch,
eyes in order to force the child
or you
to
can
use
have
their weaker
corrective
eye.
glasses.
Sometimes your physician can monitor both eyes as the child grows to see if they outgrow their strabismus. For many patients, surgery is necessary to adjust the eye muscles and straighten the eyes. Your physician will help determine the best option for you. Before surgery, your child will be put to sleep with general anesthesia. So they
Usually in
will
a
not feel
children,
any
you will have to
pain
give
during
general
the procedure.
anesthesia and then do the
To
surgery.
begin the surgery, the eye is gently held open
And in that surgery,
rotated inside
you
the eye
can,
socket. To access the eye
there are
muscles,
two
a
procedures.
small opening is made in a transparent layer of tissue called the conjunctiva. If
Shortening
the muscle
and
is pulled
lengthening.
too tightly on the eye, then the muscle attachment is moved and reattached
This is
to
lengthening
the eye in
procedure.
a different position. To strengthen a weak muscle, a section
This is
is
shortening.
removed
You are
and
cutting
then
one
reattached to the eye
small
so it will
portion
grow
and you are
tighter.
shortening the muscle.
It is common to have more
So it
than
is
one muscle
shortening or
adjusted
lengthening
on
of the
one
muscle.
eye, and in many cases, both eyes will need surgery
In a
in
weak
order for
muscle,
them
you
to
can
move together.
shorten.
At
In
Children's
a
Hospital
strong muscle, you
Colorado,
can lengthen.
most strabismus surgeries are completed in 1 to 2 hours, but plan on spending the whole day at the hospital. After the surgery, it
And
is
after the
normal for the
surgery,
eyes to feel a little
the
itchy,
child has to
but
take little
usually
care.
not very painful. If needed, pain can usually be controlled with over-the-counter medications. We will prescribe eye drops or ointment to help with the healing process and to make the eyes feel more comfortable. The eyes are often red or bloodshot for a couple weeks after the procedure.
This
But within
red
a few
eye will
days, your child
disappear
can usually
soon.
return to normal activities, except for swimming. We
Swimming
usually ask
is
patients to wait at
contraindicated
least 2 weeks
post-surgical,
before swimming.
at least for 2
While
weeks.
strabismus surgery is usually successful, studies have shown that 1 in 5 patients will need another strabismus surgery later in life. For more
And
information, visit the
20%
Children's
might
Hospital
require
Colorado website.
surgery later on the life. So, diplopia can produce loss of vision in the affected eye, and that will be irreversible. So, as early as possible, early detection of strabismus and correction will reduce the chance of loss of vision. That is, we call amblyopia. So, amblyopia is a common complication secondary due to strabismus. So, thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. If you like this particular lecture, please don't forget to press button like and subscribe. You can share with your friends. And I feel this lecture will be helpful to you in your oral exam. Once in a while, this can be asked in your theory also. And you will see good number of time patient in your everyday practice. See you in next lecture.